So this is Mr. Simmons. He comes in with a chief complaint of shortness of breath. Now, Mr. Simmons is a 42-year-old male with a past medical history of hypertension who came into the ER with a complaint of 6 weeks of shortness of breath with minimal activity. He says that he was able to walk 10 plus city blocks prior to all of this, but in the last 6 weeks he's had to reduce that to no more than 1 to 2 blocks. He has to stop to take a breath to catch his breath after just a couple of blocks. He also reports 2 piloorthopnea and paroxysmal nocturnal dyspnea. He also notes an increase in his abdominal girth over the last month. He actually tried taking castor oil and some colon cleanse tablets and Pepto-Bismol. It kind of gave him some frequent loose stool, but otherwise didn't really help his belly. He did go to his primary care doctor's office last week when he was found to have a blood pressure up in the 200s, and he was referred to the ER. But instead of going to the ER, he ended up going back to his cousin's and took some blood pressure medicine that he got from his cousin at the time. So essentially, he's been without any medications. Today, he started to get alarmed. The reason he came in today is because he started to notice shortness of breath just while getting dressed, which was unusual for him. He's also noted a dry cough during the day as well as at night. He's very fatigued. He's noticing bilateral edema in his lower extremities. He denies any fever or chills. Last night he actually had to sleep in a recliner because his orthopnea was so bad. So as far as the past medical history, he was diagnosed with hypertension 7 years ago. He was prescribed meds, but he's not taking any medications at the moment. No surgeries in the past, as I said, no medications, no known drug allergies. He used to smoke marijuana, has never used any other illicit drugs, and I can't remember his smoking history. He's a lifelong non-smoker. Review of systems. He has noted some weight gain and occasional blurry vision. Otherwise, he denies any chest pains or palpitations. On physical exam, his temperature is, he's afebrile, his blood pressure is 116/70 today. He's tachycardic at 106 per minute. He is tachypneic at 26 breaths per minute. He is a little hypoxemic with 93% saturations on room air. His BMI is 40. He's alert and oriented, pretty anxious actually, and noticeably tachypneic. His pertinent physical exam findings, other than tachycardia, is that his PMI is displaced to the mid-axillary line. He has an S1 and S2, and I also heard an S3. There is jugular venous distension to 10 centimeters above the sternal angle. Crackles also at the bases of his lungs bilaterally. The abdomen was noted to have hepatomegaly. And he had 2+ pitting edema to mid-calf.
Okay.
So to summarize, 42-year-old gentleman with 6 weeks of dyspnea, exertional dyspnea, who comes in today with acutely worsening dyspnea, weight gain, increased abdominal girth, and findings on physical exam consistent with volume overload, I think. Let me tell you his labs. His sodium is 133. Potassium is 4.2. Chloride is 110. Bicarb is 20. BUN is 24. And creatinine is 1.3. And his glucose was 86.
Did you say he was drinking alcohol? Do we know?
Why do you ask that?
Well, for one, it's a source of fluid. It might be a cause for his volume overload, and then alcohol's other effects on people's electrolytes, so it'd be good to know that.
And also, some of the findings, I know that we haven't really gone over this much yet, but could be concerning for liver problems as well.
Actually, it turns out he does. He drinks about 1 to 2 pints of vodka a day and about a case of beer on the weekends.
Okay. And he has not taken any blood pressure medicines in a couple days.
In 7 years.
7 years,
He
okay.
may have taken one of his cousin's medicines a few days ago.
Any over-the-counter meds or supplements that he might be taking?
Nope. What do you think about his BMP?
So the first thing I think to start with is just what's normal and what's abnormal. That's always a good place to start. And the sodium here is low, a little low. So,
Yeah.
little arrow. It's helpful, especially in the beginning when you're getting used to learning all the normal values. The potassium's normal. The chloride is about normal. The bicarb here is a little low, and that's going to matter when we talk about the volume status and later when you get to the acid and base problems in the body. So this is a little low, the bicarb. And what's also concerning here is the BUN is a little high. This is the urea in the body. The kidneys should be clearing. And the creatinine is high. For a man, his normal is probably 1.1, 1.3, even though it sounds like a small difference, is actually a big deal. He may be in the middle of an acute kidney injury with that number, so that's very concerning. And the sugar is probably normal if he hasn't eaten something in a couple hours.
Why do you think his sodium is low?
The differential for low sodium is complicated, and the thing we have to assume is that the physical exam findings, his presentation is going to explain the low sodium. It's probably going to be explained by the obvious things that stand out to us, but you're going to have to start with the volume status to figure out. And off the top of my head, I'm going to assume that it's due to an organ dysfunction like heart possibly, or Chris mentioned maybe a liver problem. And the BMP here is going to tell us just the concentration. That's a good thing to remember. This is just a concentration of sodium. It is not telling you the total body sodium. This only tells us the concentration. So I know that the body is having a problem with diluting the sodium too much. So this really represents a water problem, which is a really difficult concept. But when you look at the BMP, you have to think with the sodium, this is a water problem, and we're going to use our exam to figure out what is the total body volume. And usually combining those two facts, we can figure out what's actually causing the sodium to be low.
Yeah, I agree, John. I think, I always like with sodium to go back to your patient and really look at your patient and not just look at the labs. And, you really have to talk about what is the volume status of our patient at this point. And we have several things on exam here pointing to hypervolemia. You have the crackles in his lungs, you have the lower extremity edema, you have the JVD, as well as the S3 and the PMI being displaced, all pointing to perhaps volume overload in this patient. Probably more likely from the heart, like you mentioned. We do still have the hepatomegaly. Hepatomegaly could be related to heart failure, but we also, with the drinking history, would be concerned about perhaps liver problems, cirrhosis as well, but we won't go into too much details on that today. So yeah, I agree that it seems at this point to be a hypervolemic hyponatremia, and I would probably start there.
Now you say he's hypervolemic, but his creatinine is high. What do you think about that?
Well, I think one of the first questions I'd want to know is, do we have a baseline creatinine on this guy? Is this actually his baseline? The creatinine 1.3 actually in a 42-year-old male doesn't strike me as terribly abnormal. As we know, creatinine is relative to body mass, especially lean body mass and muscle mass. So actually in this patient, this might not be terribly abnormal, especially if he is a relatively muscular younger guy. Now, if this was a 90-year-old female who was extremely thin, this would be a very abnormal creatinine. So it's a little bit relative here. But assuming that his baseline creatinine is, let's say, 0.7 or 0.8, this would be considered an acute kidney injury and would be potentially concerning for that. And in a patient with heart failure, we start to think of what we kind of call cardiorenal failure, perhaps that he's not getting enough cardiac output to his kidneys. So as far as his kidneys are concerned, it's an acute kidney injury related to a pre-renal cause, the pre-renal cause being his heart failure. But once again, that's just sort of trying to put together what's going on clinically with the lab findings there.
I think it's a great discussion of how volume status can have different effects on the kidney. You have to start with the exam and what you notice on the BMP, and this is exactly how we phrase it. We always talk about, is it hypervolemic or hypovolemic? hyponatremia. If you start there, you won't go wrong, because here we've established our exam is hypervolemia. We know from the BMP that the patient has hyponatremia, the low salt, and then you worry about the other problems. In this case, an acute kidney injury we think is possible, and we'll figure out why the kidneys are injured, if they are, after we figured out these first two diagnoses. So like Chris said, if you know they're hypovolemic, then you have to ask, how can a hypervolemic patient have a kidney injury? One possible answer is they have too much volume, but it's all in the wrong place. It's in their legs, it's in their lungs, but it is not in the vasculature going to the kidney. So if you do it in the right order, you can always arrive at the answer. I think if you started with worrying about a kidney injury and try to work backwards and explain, you would get very confused very quickly. So I think I love to start here with the exam and then go to the basic labs, like the salt, and then worry about everything else, and I think you'll arrive at the answer that way.
Great. If you were to do an arterial blood gas on this patient, what do you think you might be expecting to find?
And you're really doing your arterial blood gas for two different things, right? You're looking at your acid base, and you're looking at your oxygen saturation, or your PaO2. From an acid base perspective, as John alluded to, his bicarb is a touch low. Looking at normal bicarb being about 24. It's very mildly low. If you looked at whether or not he has an anion gap, just trying to do the math on the top of my head, he does not have an anion gap according to those labs. I'm getting 3 as the anion gap, so it would be considered a non-gap acidosis. But it's extremely mild, so I would not be surprised if the pH is near normal.